Before we begin, I'd like to direct your attention to the USW COVID-19 webpage. The page is on your, or the address is on your screen now, www.usw.org/COVID-19. This page is updated continually with new information and resources, and there is an option to report workplace issues or any COVID questions that you may have. If you are on Facebook, please consider joining our USW Healthcare Workers group, where members are able to discuss their experiences with one another and share information. In addition, the Healthcare Workers Council puts out a weekly newsletter called Stat Facts that includes stories about our members, relevant sector news, and pandemic information such as changes to the CDC recommendations or NIOSH guidance. And if you already don't receive Stat Facts, you can sign up by texting HCWC to 47486. So no matter what platform you prefer, please use these resources to connect to the information that you need for your members. And we are working to be a one-stop shop for all your needs during this difficult time. With that being said, I'd like to hand this off to our International Vice President of Human Affairs, Fred Redmond. So it sounds,
okay,
it seems like we might be, Fred's on, great.
Can you hear me now? Okay, so first of all, let me thank everyone for joining in. And look, needless to say, our union is operating the same as many organizations and companies during this pandemic. Our headquarters personnel and district offices that are located in states that have ordered quarantines. Our staff is working by phone and webinars and working diligently trying to address issues that are arising every day and every hour by our members related to this COVID-19. Just for a piece of information, today our union have over 53,000 of our members who are not working because of COVID-19. And some are off temporarily, and some have been laid off because of market conditions as a result of the slowdown in the economy. But there's no sector in our union that has been under extreme stress and pressure as our healthcare sector. So you are the ones that are on the front lines of this, and besides our thoughts and prayers for each and every one of you and your families, we want to provide you with available information and resources to help us all get through this. Look, we are in uncharted waters here. Our union, nor the entire labor movement, has never dealt with anything like this. And we have been working collectively with the National AFL-CIO and healthcare professionals. We've been in collaboration with all of our departments of our union, safety and health, our legislative office, communications, social media. And it's been an all hands-on effort to try and keep up and understand issues that are affecting you, because our biggest resource is each other. But we are going to get through this. And if you have any questions during this webinar that we can't answer, we will try to get an answer for you. So look, you know, we are working every day trying to address the needs, but I cannot imagine the things that you are going through because you're on the front lines of this. And I just want you to know on behalf of our president, Tom Conway, and our entire executive board is that we're very cognizant of the stress and everything that you're dealing with on a day-to-day basis. So I'm going to hand it back over to Tamara. We have some of our folks from safety and health and political that's going to talk to you and give you some information. And, you know, we look forward in working together so that we could get through this. Okay, so Tamara, I'll turn it back to you.
Thank you, Fred. Okay, so joining us today as presenters will be Mike Wright, who is the director of the USW's Health, Safety, and Environment Department, Mark Catlin from MDC Consulting and Training, who who has years of experience being a labor health and safety activist for healthcare workers, and Anna Fenley, Director of Regulatory and State Policy. After the presenters have completed their presentation, we will have a Q&A session. So thank you all for participating, and we are going to kick things off with Mike Wright. So Mike, it's all yours.
Hi, this is Mike Wright. I'm the department head of the Health, Safety, and Environment Department for the union, and we're going to go through some basics about coronavirus. If you know all this already, and many of you do, forgive me. We wanted to make sure that that everybody was on board in the same place. So let me begin. First slide, please. So this is how the virus spreads. SARS-CoV-2, and that's the official name of the virus itself. The disease is called COVID-19, but the virus is called SARS-CoV-2. It's a respiratory virus. It enters the body through the mouth or the nose or sometimes the eyes. In that it's different than other viruses, which are, for example, bloodborne, like HIV. In the body, it invades cells deep in the respiratory system, reproduces there. That's what viruses do. They hijack your cellular machinery, and then it escapes, leaving damaged cells in its wake. And the virus particles are tiny, 900 times smaller than the width of a human hair, certainly far below what most microscopes can see. Next slide. The virus gets transmitted. Actually, go back to the last slide, if you would. It's called a coronavirus. Those are pictures of it taken through a scanning electron microscope. It's called a coronavirus because those little spikes you see coming out of it make it look like a crown. And corona, I think, is Latin for crown. It also looks like the corona of the sun, so that's how it got its name. Okay, next slide. There are three ways it is transmitted, and there's been an ongoing debate about which is the most important. For healthcare workers, they're really all important, and we have to guard against all three of them. The three are: first, droplets, things that somebody expels into the air when they cough or they sneeze. Second, fomites, which is a fancy word for just surfaces and equipment that may be contaminated by the virus. And finally, what's called an aerosol. An aerosol is a group of like very tiny particles suspended in the air, and they can stay there for a long time. We'll talk more about that in a minute. There is research that shows the virus can be found in blood, but unlike HIV/AIDS and hepatitis B, blood does not seem to be a significant route of transmission. Therefore, the OSHA bloodborne pathogen standard, which is the really one OSHA standard specific to healthcare workers, really isn't sufficient to protect against COVID-19. We've been working to get an OSHA standard for infectious disease generally, but so far we have not been successful. I think Anna will talk a little more about that fight when she comes on. Next slide, please. Droplet transmission. We're still learning about the virus, but the most common form of transmission seems to be through droplets expelled when an infected person sneezes or coughs, or when certain medical procedures are performed. A person in the path can inhale the droplets or get them on skin or clothes. The virus can't enter through your skin, but touching that area later can transfer it to the face, close enough to the nose and mouth to be breathed in. Droplets are large enough that they tend to fall to the ground fairly rapidly. And so the biggest problem with droplets is getting them on yourself or getting them on surfaces. And let's move to the next slide. Aerosol transmission. Like I said, droplets fall to the floor or other surfaces quickly, but the tiny invisible particles can linger in the air for up to 2 hours. And that mix of air and the particles is called an aerosol. Droplets contain much more virus, so this is a less likely route in terms of essentially catching the virus. But aerosol transmission can happen, especially in healthcare, and therefore we need pretty elaborate protective equipment to stop it. Next slide. Fomite transmission. Fomite is a surface, as I said before, or an inanimate object that can become contaminated, and then it can transfer the virus to a person. Fomites can become contaminated in the same way as people do, mostly through droplets, sometimes through aerosols. Fomites are why protective gear and frequent hand washing and disinfection of surfaces and equipment are really so important. Next slide. How long does a virus last on a fomite? There's research, and so far this has only been reported in the New England Journal of Medicine and only in a letter to the editors. So it's really very early first stage research. But the research indicates that cardboard that the virus can be supported on cardboard and be infectious for up to 24 hours. Steel, hard surfaces like steel and hard plastic, it can be 2 or 3 days. And we don't know about cloth yet. The research hasn't been done, or at least I haven't seen it, and I've been looking. But viruses degrade more quickly on porous surfaces. That's basically because the porous surface kind of sucks moisture out of the virus and dries it and inactivates it more quickly than a solid surface. So we don't know about cloth, but we know that other viruses degrade on cloth in less than 24 hours. So that's what we think about cloth now. Now notice that though that what we're talking about is disinfecting surfaces and changing protective equipment much more frequently than any of those numbers. Now there is a report you may have seen, go back, that viral DNA was found on cruise ships weeks after the passengers had departed, and that got a momentary stir in the press because people interpreted that as saying that the virus itself remained on those surfaces. But what was really left was the breakdown product of the virus. That material was not infected. Was not infectious. And it's basically what's left when the virus breaks down. So we think these numbers, even though they're quite preliminary, are pretty good. Next slide. So what's the course of contagion? We believe that symptoms appear 2 to 14 days after exposure, and the average is 5 days. But that's for people who really are symptomatic. And there's growing evidence that people can contract the virus, can become infectious, and never have symptoms. And in the end, they recover and they don't even know they were sick. So that's one of the things that makes the virus dangerous, because people can spread it without knowing they're spreading it. That can also happen because people can infect others before symptoms appear. We think probably the virus becomes infectious for 2 or 3 days before the symptoms appear. And people can also infect others for 2 or 3 days after recovery. Now, we don't know that specifically for this virus, but it's true for other coronaviruses, and it makes sense it's true for this one as well. So people can be infectious when they don't know it, both because they never know that they were infected, and because they can be infectious before the symptoms appear and after the symptoms go away. However, given all that, a person with symptoms is much more likely to infect others. The viral load is heavier when people are symptomatic, and they are much more likely to sneeze and cough. And so the most infectious person is somebody who is actually displaying symptoms, we think. Next slide, please. And finally, what are the symptoms? We've heard different numbers, and I should say these are these are rough estimates, and they're kind of the midpoint of the range of estimates. But we think that 90% of all the people who have the virus and have symptoms have fever. That's the most common symptom. Cough is a secondary symptom, but it's pretty prevalent too. It's in about 70% of the cases. And often that cough is a dry cough. That is to say, one where you're not producing mucus and spitting things up. Fatigue is present in about 60% of those who show symptoms. Appetite loss in about 60%. Shortness of breath in about 35%, and that, along with fever, are the two most significant symptoms in terms of their danger. Sputum production, about 30%, muscle aches about 30%, and there have been reports of people who have lost their sense of smell and their sense of taste. We don't yet know how prevalent that is, but it seems to be a real symptom. And as I said before, an unknown number of infected people, and we don't know that number yet because we don't know how many people have had the virus and have recovered from it without ever showing symptoms. So an unknown number of infected people have no symptoms. They can probably infect others without ever knowing they had the virus. As I said before, however, symptomatic people are probably the most likely to spread it. So thank you, and let me turn it back to Tamara.
Thank you for that, Mike. All right, so our next speaker is Mark Catlin with MDC Consulting. Mark has years and years of health and safety experience, specifically with healthcare workers. Mark, take it away.
I'm sorry, can you hear me now?
We can hear you.
Okay, thank you. I'm trying to get my slides up. Okay, can you see the first slide?
Yep, we can see it fine. Thanks, Mark.
Okay, so thank you. I'm honored to be here, and I wanted to thank you, as the other speakers have, for the work of you and your members during this really unprecedented crisis. What I want to go through are some of the issues of respiratory protection. And as Mike has described with the issue of aerosol spread, we think this is an important issue that's really been very much confused, and hopefully this will provide some help. I want to go back to this. This is the current CDC guidance for protecting healthcare, for protections for workers in healthcare settings. And I want to start off by just pointing out that CDC guidance is just that. It's really voluntary for your employers to follow. And when infectious disease folks are recommending CDC guidance, it's not like OSHA standards, like the bloodborne pathogen standard, that is a mandatory enforceable standard. These are guidances that come down from the CDC to health departments to your facility, and they don't have to follow these. But this is our strongest guidance we have now. So to start off, it says right up front to put on a respirator before entry into a patient room or care area, and only if respirators are not available to provide face masks. And so I think this is an important part of this guidance to go back to. We're often seeing healthcare employers are saying that there's no requirement for respirators anymore, that face mask and droplet spread is all that's there, and they often will refer to the World Health Organization and not to the CDC. So I think we need to keep a focus on this. It also says that when the supply chain is restored, if you're not able to get N95s for your facility, when the supply chain is restored, facilities need to go back to using respirators. And so I think this is also a second important issue. In addition to using respirators in patient care areas, it's especially important that respiratory protection be used for these aerosol generating procedures that put folks at high risk, like intubation, bronchoscopies, and others. And I think that's something that's consistent across the CDC and WHO guidance, is to do those kind of protections. So to go back to sort of, as Mike was pointing out, this idea of aerosol spread, this is such a huge issue in terms of worker protection. If you follow the infectious control professions kind of thinking about this, and the droplet spread is all large droplets that fall away quickly, and you're only worried about exposure from 3 to 6 feet away. If patient A has or is presumed to have the virus, and the healthcare worker B is within 3 to 6 feet, then there's a concern, and the infection control people would recommend surgical masks to protect against droplet spread. But we think that the science clearly shows that this aerosol spread of large and small droplets is what's really happening. And so healthcare worker B needs to be protected both from the large droplets, but also the small droplets. And healthcare worker C, who's further away, also needs to be protected from the aerosol. And so I think as you think about your work sites and your members, I think it's important to keep this in mind. What we refer to this is actually thinking of short distance airborne spread. We're not thinking about it necessarily going through ventilation systems and going long distances, but at least short distance aerosol spread through patient rooms and in enclosed patient care areas. Okay. So just to think about that is, in this setting, patient A is known or suspected to have the virus. Which healthcare worker B, C, or D needs a respirator? Well, many healthcare facilities are now saying nobody needs a respirator. That the healthcare worker B only needs a surgical mask, and healthcare worker C is fine because they're more than 6 feet away. And so what we would think would be healthcare workers B and C both need to be wearing respirators. They're in this enclosed room with the patient. Healthcare worker D, however, would not, assuming that the exposures to the virus are controlled outside of this enclosed space. Okay. So before I talk specifically about respirators, I wanted just to go back to a basic concept of occupational health, which is called the hierarchy of controls. And so much of the focus with the healthcare employers I've been dealing with, our members, but also the media, is only on this PPE, personal protective equipment. And it's really the last option that we should be looking at to control the health hazards that healthcare workers face. So once we have a vaccine, there'll be a substitution that can help eliminate the risk, but engineering controls like negative pressure rooms and respiratory etiquette, masking patients, work practices, of course, hand washing is always mentioned, but things like cohorting, early recognition of potential cases, and training of all the staff, including environmental service workers, is also important. Usually in healthcare, there's a need to have a combination of all these methods together, but we really need to try to look and get our employers to look upstream and not only focus on the things our members are wearing. Okay. And there's also been a lot of confusion about surgical masks and respirators. And over the years, I've actually heard a lot of infection control professionals and healthcare managers say, well, these two pieces of equipment look the same. Let's just assume they're the same. And they're incredibly different. Okay. An N95 respirator, which is one of the types of respiratory protection for healthcare workers, is designed to protect the healthcare worker from airborne particles being inhaled. Okay. So there's a tight fit against the face. The filter material on the facepiece is designed to filter out 95% of all these large and small particles. Surgical mask is designed primarily to keep the droplets and stuff inside a sick person from spewing to the outside. So masking a patient with a surgical mask is a really good control option. And then a healthcare worker wears an N95. Okay. When healthcare workers are wearing surgical masks, it can provide protection against the large droplets that are from coughing and sneezing that might get to the mucous membranes of the nose and mouth. But this does not protect against the small droplets that are airborne. It doesn't seal tightly against the face, and the filter is not anywhere near as efficient as the N95 filter. Okay. And I think one thing I just drives me crazy when I'm listening to the news is the word mask is used to describe both of these pieces of equipment. And I hear this in healthcare settings, and it's incredibly confusing because if someone says we're going to give people a mask or they've been using masks, it's really critical to find out, are they using surgical masks, which have a different purpose, or are they using N95? So I urge you to really push your employers, or when people start saying where they're providing masks, to identify which one they are, because respirator is a much better piece of equipment to protect our members from aerosol spread. Okay. There's also a lot of creative ideas out there. I mean, there are a lot of people with good intentions making homemade masks for healthcare workers in hospitals because of the shortages, the reported shortages. This nurse anesthetist in the middle that I talked to, she actually made a fairly interesting homemade respirator out of parts from her OR, including HEPA filters and things used for patients. And there's this bizarre idea back on the left in 2009 from H1N1 about wearing surgical masks with stockings pulled over your head, and that would be equivalent to an N95. It's a crazy idea. So what we really want for healthcare workers are real certified, NIOSH certified respirators that we have confidence can protect their health. Okay. So on the left are some common types of respirators used in healthcare. And the one on the left are the N95s that most of you are probably most commonly seen. There's a cup design on the top. There's a duckbill type on the side, and different manufacturers, and they come in different sizes. But essentially, they work about the same. If they seal tightly against the face, the filters are designed to filter out 95% of the large and small droplets from the air that contain the infectious particles. Many healthcare facilities have a limited number of the second one from the left, powered air purifying respirators. These provide a much higher level of protection to our members. Some are tight fitting, some are not, but they have a better filter, and they have a battery assist to help with moving the air across our members' faces. And so these are often used in TB settings. They're often used in these aerosol generating high risk procedures. And some hospitals are using these as much as they can for this virus. Another version of a powered air purifying respirator is the second one from the right, and that's used for first receiver teams for mass decontamination. There's no reason these can't be put into practice to be used for COVID-19 care. The one problem is the PAPRs are reusable, and they have to be cleaned and disinfected, and so the shroud on this first receiver PAPR makes that a little more difficult. But there are some ways around that. And the last respirator on the right is one that most of you probably have never seen, or you've seen it from your engineering staff in your hospitals using these against various types of dust and chemicals that they might run into. However, there's a study done a few years ago by the National Academy of Science looking at the possibility of these reusable elastomeric respirators with filters that are appropriate for aerosols, that these could be used for both routine use against infectious disease, but also certainly may have a role to play during issues of surge control. So I have the link here to this National Academy of Science report. It's only about a year old. It's a very good report, and I think this is when you go back to the idea of an employer claiming N95 shortages, have they looked at, or would they look at this as a possibility? Okay. And these on the left here, these types of reusable elastomeric air purifying respirators with these P100 or equivalent to a HEPA filter, these, where they've been used, these would typically be assigned one to each healthcare worker. They would last at least a year, and the filters might have to be changed more frequently, but not on a very frequent basis at all, as long as they're properly cared for and disinfected. One of the real advantages is each healthcare worker gets their respirator, and it's theirs to take care of as one of their own tools, and only they have it on their face. Okay, this provides actually a better seal around the face, and it provides the purple filters are actually better filters than N95s, and this respirator is easier to get a user seal check to ensure that when you put it on, it's actually fitted on your face right. And then the cost of these is between $20 to $45 each. Okay. These have been successfully used for more than 20 years at this Texas Center for Infectious Disease in San Antonio that has been seeing tuberculosis patients for a long time, but they're also seeing coronavirus patients, and I've been in touch with them recently to confirm that they are still successfully using these and happy to help other hospital systems transition over from N95 to this style of respirator. These are also used currently and have been used by the University of Maryland Medical System in Baltimore, near where I live, since 2000 and 10. And I'm currently working with 2 hospital systems that are looking to pilot test these as a substitute for N95s. Okay. So if we go back to the issues of respiratory protection, and your employers are claiming that there are known or anticipated shortages of N95s, they're allowed to do, according to the CDC guidance reference at the bottom here, they're allowed to do this extended use and limited reuse of these N95 respirators. These filtering face pieces generally are only supposed to be used once and then thrown away. Oh, hello? Hello, am I back? Can you hear me? Hello, am I there?
We can hear you.
Okay, thank you. Okay. So
I'm not sure what that was, but you can continue.
Okay. It's the new life we have for platforms. Okay. So if your employer is going to go back, is going to look at doing extended use and limited reuse of N95s, the first couple points here are important. They're supposed to actually first consider minimizing number of healthcare workers that are using respiratory protection, and relook at their engineering and administrative controls to see if they can extend the use of the N95 supply by going up the hierarchy of controls and not just putting respirators on everybody. They also are supposed to look at alternatives to N95. So the elastomeric respirator I just mentioned is one alternative. Powered or purifying respirators are another. But there are other classes of filtering facepiece respirators used in other sectors, and there has been a call for these other respirators to be provided by construction firms and others. So they should be looking for these alternative types of respirators. Okay, if they are going to do extended use, which is healthcare workers continually wearing the N95 between patients on the same shift instead of replacing them after each patient and discussing and discarding them. Okay, they still need to have some limitations on that use. I mean, what we're hearing now is healthcare workers are given one N95 and told to make this last for the whole shift or make it last for the whole week. And this idea of using it, taking it on and off multiple times during the shift or over several shifts is considered to be a reuse. But both of these require the healthcare workers to use these in ways they're not normally supposed to be used. Okay? And so if this is the case, healthcare facilities have to develop very clear written procedures so that healthcare workers understand how to do this. They need to discard N95 respirators if they're used during an aerosol generating procedure because of the high potential for lots of exposure to the virus. They need to discard these if they're contaminated with blood or other secretions and bodily fluids. It can be helpful to use a cleanable face shield over the N95 to help keep it protected and to allow it to be used more frequently. It's important that healthcare workers that are using this redawning doffing of these more than once, that they have to be protected from their hands getting contaminated and touching their face. So cleaning their hands with soap and water or sanitizing with sanitizers is important after touching and adjusting the respirators. And then they have to, if you're going to use these more than one shift, these respirators need to be stored so that nobody else would use the same respirator. The recommendation often has been to hang these and let them air dry overnight, or the other recommendation we've been seeing is to put them in paper bags so that there's some ability for them to dry out overnight, and then do that between uses. They can also be labeled, but there's inherent problems with this of people taking respirators that have been used in and out of these paper bags or off of hangers and touching the front surface and becoming contaminated. So there needs to be really clear written procedures, and this is only to be done with proven shortages, proven supply problems, and this should not become routine. Okay. And just this morning came out, you probably heard this guidance came out. You've probably been hearing a lot about how to disinfect these respirators, and they're not meant to be disinfected, but during this crisis, there is the CDC guidance does say that maybe the disinfecting might be something that has to be done to increase the supply. There's very limited research on this, but we're seeing some potential methods that are being put out there in terms of UV light irradiation, hydrogen peroxide vapor sterilization, and then moist heat. At this point, NIOSH, who certifies respirators, hasn't approved any of these, and the manufacturers have not approved any of these also for their equipment. These disinfecting methods, it's not clear if they're how effective they are, and they also may damage the N95 respirator so it doesn't fit or work properly. Okay, so here's the guidance on that, and I wanted to make sure you had that. Okay, and finally, as I finish up here, I think it's important. I didn't want to not talk about this unique California OSHA standard. About 10 years ago, we won a standard in California on the aerosol transmittable disease. This is the only OSHA, this is a state OSHA standard. It's the only OSHA standard that deals with droplet and airborne spread disease. It covers healthcare workers and other hospital and other healthcare workers and some public safety workers in California. It currently considers COVID-19 as an airborne and droplet spread disease, although the hospitals have been working hard in California to have it designated as a droplet spread disease only, so they don't have to deal with the respirator issue, but that's not yet happened. Now, this is only mandatory and enforceable in California, but it's a great model for other parts of the country. So I wanted to make sure you all know about this. This workplace guide just came out from CalOSHA, and I can send the link to that so everybody can get a hold of that to understand the standard. And two things here on the right is the is kind of the major categories of this standard. It's considered a comprehensive OSHA standard in a way that like bloodborne pathogens is. So there's lots of elements to this. You see respiratory protection number G is only one of many. The most important part of this is letter D, the exposure control plan. And CalOSHA has developed this on the left here, this template exposure control plan for employers to help them comply with the ATD standard in California. But it's a really good model, I think, of an exposure control plan in healthcare. And this is actually a fillable form, so it made it easy for employers to fill out. And there's the link that you can go to download that for yourself. The other thing I wanted to mention was under H, medical services, this standard provides that if a healthcare worker is sent home on precautionary isolation, which we see a lot here with this virus, that the pay, benefits, and the job of that healthcare worker is fully protected until they can return to work while they're while they're waiting to see if they're going to develop the disease or not. And I think that's a really important issue that has certainly gotten a lot of attention. So with that, I want to finish up by just going back to the first slide and just sort of reminding folks again that the current CDC guidance does say respirators before entry into patient rooms and respirators for aerosol generating procedures. It's only if there are shortages that face masks are supposed to be used. And once the supply chain is restored, the employer should be going back to respiratory protection for healthcare members. So with that, I'll look forward to answering questions, and I'll pass it back to Tamara. Thank you.
Thank you for that, Mark. This information is changing hourly, daily. NIOSH put out some guidance earlier today, specifically on the N95 respirator decontamination in response to CDC's position. And the union will have a communication piece out about that within the next, I'd say, 24 to 48 hours. So I just wanted to give folks a heads up that we're also following up on that as well. So thank you very much, Mark. That was incredibly informative. Up next is Anna Fenley, our Director of Regulatory and State Policy. So it's all yours, Anna. Thank you.
Thanks, T. Good afternoon, everyone. I was asked to just chat with you all for a little bit about some of the federal legislative activity that's been happening for the national response. There's a lot of information, and at the end of my presentation, I'm actually going to show you where you can go to access most of this. Most of it is and will be available to you on the Steelworkers webpage. So just to give some political context, Congress has passed 3 packages so far for the immediate response. One was passed on March 6th, and this was a bill that was primarily just to give extra money to federal agencies to start the response. So it gave money to like the Department of Health and Human Services and the FDA to get started on the development and purchase of vaccines and diagnostic tools and treatment, and some other things. So that was the crux of that one. The other two bills we're going to dive into just a little bit more. But the one caution I want to say is these are happening fast and furious. Many of these bills are being implemented and carried out by federal agencies like the IRS and the Department of Labor and the Department of Treasury and the Small Business Administration. And those agencies are still continuing to put out guidance and figure out exactly how they're going to implement. So things are still changing related to these. So the second package, called the Families First Coronavirus Response Act, this did a few things, and one of the things was it said that testing for COVID-19 had to be covered by health insurers, and the federal government provides free testing for people who are uninsured. And then it had some really important provisions on emergency paid sick leave and some expansions to family medical leave, expansions to the FMLA. And the real challenge with those provisions is that healthcare workers are exempted from those expansions. And we just over the weekend found out how DOL is defining a healthcare worker, and you can see that on the slide, but it's basically anyone employed at any institution that could be considered a healthcare facility. So we are definitely working to change that, but that's something that's really important for folks to know. I know we've heard from a lot of you about that. The third package that was passed was just passed last week. Its short name is the CARES Act. It is a massive package, $2 trillion. And you can see on the slide, the chart, that there are several categories of aid. Aid to workers and families, aid to corporations and businesses, and then money that goes to state and local governments, healthcare providers, and some other places as well. To dig into those a little bit, the first thing I want to say is everything that I'm talking about now, healthcare workers can access. Healthcare workers are only exempted from those paid sick leave and the expansion to FMLA. If a healthcare worker is laid off, they do have access to this expanded unemployment insurance. So the bill that passed did a few things related to unemployment insurance, provides an additional 13 weeks for people who exhaust regular state benefits. It provides an extra $600 every week of unemployment on top of your state benefits level. And it's just across the board $600 plus up until the end of July. These benefits were expanded to people who are not usually eligible for unemployment. So people who work part-time or are part of the gig economy. And the bill also is providing funding for states if they waive the waiting week. Many weeks have a waiting week or a job search requirement or something like that as a condition. But the bill tried to get at that and incentivize states to at least waive that waiting week. A second part of the bill for working Americans is that every person who makes under $75,000 a year is going to get a check for $1,200. We expect those checks to come next week, the week of April 6th. This is basically a brand new tax credit for the 2020 tax year that people are getting in advance of filing their taxes next year. If you file, if in your tax, it's based on your taxes from 2018 and 2019, if you've already filed those. So if you make less than $75,000, then you get the full amount. If you make between $75,000 a year and $99,000 a year, then that'll be reduced on a sliding scale, basically, and you'll get something. And for people who make more than that, they will not get anything. So that's coming to everyone, basically, who filed taxes in the last 2 years. There are also a number of just consumer provisions that are helpful. So one example is student loan debt relief. So any federal student loans payments are going to be automatically suspended for the next 6 months. Interest is not going to accrue. So that could be a huge help to people's paychecks. This third package, the CARES Act, also provided lots of funds for personal protective equipment, although we are arguing that more needed to be done. So it provided $16 billion for the Strategic National Stockpile to buy PPE so that it can be distributed. And it provided $1 billion to start supporting increased production of PPE. That again is something that we've said we really need more money. $1 billion sounds like a lot, but it really doesn't go that far in this situation. The bill also does a couple things. I mean, it directs some studies on the domestic medical supply chain, looking at some of these critical materials that we need and that we can't get right now. And then another thing that really is for frontline workers is there is funding for childcare and development block grants to help people like healthcare workers who still have to go to work and whose kids are not in school. The bill also includes a number of provisions, a huge chunk that goes to healthcare facilities generally. So the one that I want to mention on this slide is the first one, which is $100 billion to reimburse healthcare facilities for expenses or lost revenue for this response. And it's important to note that the bill does not restrict uses for this funding. So it doesn't say that they have to use it for PPE, and it doesn't say that they can't use it for payroll. So it is to be determined if a federal agency in some way restricts that in some way. But at this point right now, there are no restrictions on the use of that funding. And then there are a number of other mechanisms that the federal government is using to try to provide money to healthcare facilities and healthcare providers, increasing Medicare payment rates, and upping the hospital preparedness grant program. Just to give you a sense, I won't dwell on this very much. There are also a slew of programs of assistance for employers. These are primarily aimed at keeping workers on the payroll. So there are tax credits that basically let employers deduct wages that they're paying if employers are having decreased operations or aren't actually operating. There are loans for small businesses. There are loans for large employers. There's some other tax provisions. And it's important to note that healthcare employers are the same as everyone else when you're looking at these buckets. So these buckets of assistance are accessible for healthcare employers. And then the CARES Act also provides assistance for state and local governments. So this is a big bucket of $150 billion in relief to help with their response. It's not detailed on these slides, but there's also money that goes to school systems and education. There's money for local public transit systems, money for states to help with carrying out elections. So there's just a lot of money being thrown out there to states and local governments. So I think really the crux is what's missing from this legislation. And this kind of answers our question of what are we continuing to push for in the fourth bill that Congress is now starting to get to work on. We have this list on the screen. Two of the first things are the three first things are incredibly important for our healthcare workers, we know. One is a requirement that OSHA develop an emergency temporary standard to protect frontline workers. And this is something we've been asking the Trump administration to do for the last month. The Trump administration could just do it, but they have not. So we are pushing Congress to require them to do it. So that's one big important thing. A second thing we're pushing for is expansion of those paid sick days and paid leave provisions that exempted healthcare workers. We're trying to get those exemptions taken out so that everyone qualifies. We are working on provisions to significantly boost the supply of personal protective equipment. There are a number of things that need to happen, but that's obviously crucial for healthcare workers and lots of other people. And then there are some other ancillary things that are not directly related to healthcare workers, but related to workers in general, like making sure that our pension plans don't collapse, making sure that workers who are laid off are able to make COBRA payments and have access to the healthcare system. And then immigrant workers were entirely left out, which is unconscionable, really. So the last thing just to mention briefly is the Defense Production Act. And this is something that is already law. It was not included in any of these coronavirus packages specifically, except for some funding to help activate it. So this is a law that exists that gives the president the authority related to manufactured goods for national defense purposes. And it really does a few things. I mean, it nationalizes the distribution of whatever the manufactured good is. And in this case, it would be personal protective equipment, ventilators, that kind of thing. It prioritizes the federal government as a purchaser. So the federal government gets to buy before everyone else. And it provides financial incentives for manufacturers to be able to develop and maintain and ramp up domestic manufacturing of some of these technologies and their components. So President Trump has invoked this authority, but hasn't really used it yet. There is a bill in Congress that we are supporting called the Medical Supply Chain Emergency Act, which requires the president to actually use this authority. And luckily, we are not only a healthcare union, we're also a manufacturing union. So we are talking with lots of our locals and various employers, manufacturers, and looking at supply chains so that we can make some very concrete recommendations to the administration about facilities and products and supply chains to really help the country get boosting on PPE and other materials production. So I only had 15 minutes. I went through a lot of information, but just before I hand it back, I just want to show you quickly, I think most people can see my screen, where you can find much of this information. And it's now, hopefully you can see, this is the Steelworkers COVID-19 webpage. And if you just go to that webpage and scroll down a little bit to latest news, if you click on the article information on emergency legislative responses to the COVID pandemic, that's where you can find a lot of this information, and many of the slides that I presented here should be posted there later today if they're not already up there. So hopefully that is helpful to everyone, and I'm happy to take questions, and I will toss it back to you, T.
Thanks, Anna. That was incredibly informative. It looks like we're getting to the end of the hour here, and now is the time for folks to submit any questions that they may need answered. Ashley, do we have any questions for the presenters?
So actually, we do. I have two questions. The first, I'm going to unmute you, Mike. We'll go to Mike Wright. And the question is, do we know how many of our members are impacted by the virus, meaning that they have contracted the virus and are being paid by the employer? Also, is there a mechanism, or is the USW trying to capture this information?
Well, at this point, the answers are no and no. Nobody really knows how many people have been impacted by the virus because we don't know how many people have it and don't know it. We also don't have a way of really gathering information about how many of our members are off work or are considered to be in essential industries. We've seen places that where employers have said, you know, we're an essential industry, where we kind of question that. For example, in Texas, a manufacturer of luxury motorhomes was able to get defined as a essential industry. So nobody really has a good handle on any of those numbers at this point. We've got estimates, but not really solid numbers.
All right, thank you. And then the second question, I'm going to give to Mark Catlin, and then Mike, if you have anything to add, I'll have you unmuted as well. And it is, when thinking of mask usage in outpatient settings, when there has been a pre-screening for symptoms for COVID-19 to filter out symptomatic patients, our site is stating that a level 1 procedure mask should be worn all day long without changing. What are the concerns about this situation? And are there concerns about procedure masks versus surgical masks when thinking of viral load of non-symptomatic patients who are not wearing masks?
Yeah, good. It's a good question, and I think it's, you know, this is something that facilities should be doing, is trying to identify suspect patients as early as possible before they get into the healthcare system. So, but for those healthcare members who have to be doing that work, I mean, we'd prefer that they're wearing N95 or better respiratory protection, just because of what their potential exposure is, and this whole issue of, because of this issue of aerosol spread. So the, you know, whether it's, you know, non-symptomatic patients that might be spreading some virus, but patients that are asymptomatic and haven't turned positive yet. But there are things that could be done up the chain in terms of work practices and engineering controls that might be able to protect our members in addition to using protective gear. And I'd be happy to talk to you more about this in offline. And Mike, Mike may have good thoughts too.
I really have nothing to add. I think Mark answered that very well.
Okay.
All right. So there are no additional questions in the chat box. And with that, Tamara, I will toss it back over to you.
Thank you, Ashley. Well, that concludes today's webinar. I want to thank everyone for participating. I know that there may be some additional questions that folks have out there. Please feel free to get in touch with us. You can reach us at usw.org/COVID-19, where you can submit questions that go directly to myself and the Health and Safety Department through our new media department. We will be updating that resource page regularly, and check out the Healthcare Workers Council Facebook page. Pardon me. So I just want to say thank you all for calling in, and our presenters for a really educational experience. Solidarity forever, and stay safe out there. Thank you. Goodbye.